Good morning, everyone. My name is Susan Walther. I'm the department head for the Health Information Management Program at Greenville Technical College in Greenville, South Carolina. Today, it is my pleasure to briefly discuss with you the ICD-10 PCS coding guidelines. I'm going to be using the AHIMA Virtual Lab 3M Coding and Reimbursement software. I'm also going to be using some slides from the textbook that we use in our coding classes, which is ICD-10 CMPCS Coding Theory and Practice, the 2016 edition by Lovison and published by Elsevier. And then I'm also going to take you to the cms.gov website, which I find extremely helpful. It's important to understand that there is a significant difference between ICD-9 and ICD-10. In ICD-9, the coding procedures was very similar to coding the diagnosis codes. Codes were either 3 to 4 digits. They included a decimal after the second character, and they were numeric. In ICD-10, the structure is completely different. All codes are 7 characters. There are no decimal points used in the codes at all. They are alphanumeric, so you have to be careful when you're writing your codes that you can distinguish between different characters that look very similar. In the procedural coding system, we have a table that takes the place of the we have an index, but the table takes the place of the tabular. And one of those things unique to the procedural coding system is that you can code directly from the table. You do not have to use the index. One of the tools that we use with the procedural coding system are some general equivalency maps that have been created by CMS. You literally can go into these maps and look up an ICD-9 code, and it will tell you what the corresponding ICD-10 code is, or you can go into an ICD-10 table and it will demonstrate for you the PCS codes. And I'm going to pull a couple of those over for you. When we're in CMS, when we go to cms.gov, we choose Medicare. Once we choose Medicare, then we go down to coding and we choose ICD-10, and then we choose the PCS and GEMS. And I'm going to show you what these tables look like real quickly. For instance, if I wanted to compare these, let's say that I am in the PCS table and I am looking for a particular code. I'm looking at 5A0522C. That is my PCS code. That comparable code in ICD-9 is 00.49. And it's just the same thing with the ICD-9 table. If I go into I9 and I look at the code 00.01, that code maps to 6A750Z4 in ICD-10. So these GEMS are very helpful if you're trying to do comparison coding, if you want to look at how you coded it in I9 and then see how you should be coding it in I10. So these are great tools, and I cannot stress enough how valuable CMS is with this transition. They have all types of tools for you to use in this transition to ICD-10. You will find the coding guidelines for ICD-10 on their website as well, and it's very important for you to print those out and read those and understand the different aspects. The other thing I want to demonstrate for you from the CMS website is if you go to Outreach and Education and then to Get Training, You can go to the Medicare Learning Network and you can actually choose web-based training courses, and they have a number of web-based training courses for PCS and tools for PCS. Web-based training. We use these in our curriculum very often, and you can see that for coding. They do have some tools for you to use, and so I strongly recommend this website as well. Some tips. In the procedural coding system, the letter O is not used. It is the number 0. So you should get into the habit of saying 0 and not O when you're looking at those codes, because O is used in the clinical modification and the diagnosis coding. So when I write a procedure code and I write that 0, I put a slash through it, a line through it, like a stop sign, to remind me that in fact it is not a 0. It's not an O, but it's a 0. The number 2 can easily be confused with a Z. Both a 2 and a Z are used in PCS. So I usually put a little line through my Z, like right there. I'll put a line through it so that I know it's a Z and not a 2. 5 can be confused with S. You just need to write your 5s very clearly. And U can be confused with V. So you really have to pay attention to your penmanship when you are writing these codes down. I'm not going to begin to go over all of the guidelines, but there are some that I think that are a little distinct that are relevant. When you're coding a closed surgical procedure and it converts to an open procedure, the reason for converting that procedure to an open procedure should be coded. And then if it's a laparoscopic procedure that's converted to an open procedure, you're going to have 2 procedure codes. And the initial laparoscopic attempt is coded to an inspection. And then the definitive open procedure is coded. And of course, that definitive open procedure will be the principal diagnosis code. New to ICD-10 this fall are actually diagnosis codes for converting a closed to an open. So those are also codes that you can add from a diagnosis coding perspective. Guideline A11 tells us that it's the coder's responsibility to determine what the documentation in the medical record equates to in the PCS definitions. Physicians are not expected to use these terms or use those terminologies. It would not be appropriate for a coder to query a physician if the correlation between the documentation and the PCS terms is clear. And an example is a partial resection. Resection is a root operation. You must know the definition of root operation. If it's a partial resection in PCS, we actually code it to an excision. So it would be inappropriate to query a physician and say, oh, was this partial resection really an excision? That would be entirely inappropriate. It's your responsibility to know that. If in fact all of the organ is not removed, then it's an excision, not a resection. Guideline B38 tells us that PCS contains specific body parts for anatomic subdivisions of a body part, and examples are like the lobes of the lungs or the lobes of the liver or the regions of the intestines. And if one of these subdivisions is completely removed, we use the root operation resection and not excision. So for instance, if a left lower lobe is removed, then we would code to the root operation of resection and not excision, because that lobe is an anatomic subdivision within PCS. And actually, when you're coding a wedge resection of, say, the left lower lobe, that is coded to an excision, and it codes to table 0BT. Let me do something here real quick. And if we are in 3M in the Procedure tab, if we type in resection lung, we can find lower lobe left, and resection is cutting out or off without replacement all of a body part. However, if we're doing a wedge resection, we are coding to of the left lower lobe, we are coding to the root operation of excision, which is a portion of a body part. And I'm going to go over that procedural coding system as soon as we kind of make it through these guidelines. For bilateral procedures, a bilateral procedure is exactly the same procedures performed on a paired anatomic organ or tissue. If there is a single procedure code that includes bilaterals such as ovaries or fallopian tubes, then you can use that bilateral procedure code, but if not, you have to code each body part distinctly. And one of the wonderful aspects of the procedural coding system is the specificity. So for instance, if we have a knee replacement, there is not a code for bilateral knees. So you actually end up using two codes, one for the right knee and one for the left knee. Let's look at table 0, U, and then T. And this is actually, we're in the female reproductive system, and as we look at this table with these body parts, you can see that we have a body part for a right ovary, a left ovary, and then a bilateral ovary, and then the same thing with fallopian tubes. We can code the right tube, the left tube, or bilateral fallopian tubes. So that is an example of using a bilateral code. Now, when lymph nodes are removed, the root operation for this is excision, unless there's documentation that the entire lymph node chain was removed. In that case, then we are coding a resection. So when you're taking out lymph nodes, you code excision unless they document removing the entire lymph node chain. Now, the structure of the procedural coding system codes. Every character is 7 characters. Each character has a specific aspect for that procedure, and the codes are alphanumeric. When we look at the alphabetical index, there are 2 types of terms. You can look up codes based on the root operation or the general type of the procedure. There are some common procedure terms. There are not any eponyms or acronyms used in the index. And so let's take a look at this. When we're looking at the root operations, oh, come on. In the index. Typically, one of the easiest things to do is to know what your root operation is. But if you're not sure about the root operation, you can look up the procedure. For instance, we have, as an example, an abdominoplasty. And an abdominoplasty can be one of several root operations: alteration, repair, or supplement. If we know some of the most common root operations used are excision and resection, and I can go to excision appendix. And this would be taking out a part of the appendix. The table, the index actually sends me to the table, and once I get to the table, I actually complete the coding for this particular procedure. Another very common root operation is resection, and again, if I do resection and appendix, it sends me to another table where the root operation is resection. As we look at the PCS table, it's divided into 16 sections, and we're going to take a look at those. These are the 16 sections that are used in the procedural coding system. The sections that you typically would most commonly use are medical surgical, obstetrics, placement administration, extracorporeal assistance and performance and therapies, possibly substance abuse treatment. The procedural coding system was designed for CMS by 3M. It is specifically and only used in the inpatient setting. So I'm not sure why we have many procedures that would never be used in an inpatient setting, procedures that don't meet the definition of a significant procedure, which is what we are coding, but they're listed here. We briefly go over them in class. I show them to the students and then clarify for them that based on my experience, I'm not sure that they would use many of these different sections. We're going to look at medical surgical, which is the one that is most commonly used. And when we look at medical surgical, these are the body systems. And so sometimes the challenge is knowing which body system you're going to be using for your particular procedure. And this is why anatomy and physiology knowledge is so important in the procedural coding system. Once you have chosen a particular body system, and I'm going to choose gastrointestinal, we have the list of the root operations. Within the medical surgical section, the definition of the root operation is exactly the same for every particular body system. And there's a question mark here. If I click on this question mark, I can actually go down and read the definition of each of these root operations. To be successful in coding in the procedural coding system, you must understand root operations, you must understand approaches, and it's absolutely critical. And of course, following the guidelines. I'm going to choose the root operation of excision. And once we get into excision, then we have body parts. We have approach, device, and qualifier. Body part, you can click on the question mark and it will define for you or identify for you body parts that you may have your procedure performed on, but they're not included in the body part table, and so it tells you what body part to use. For instance, the pylorus of the stomach includes the pyloric antrum, the pyloric canal, the pyloric sphincter. And so this is very helpful. There are wonderful additional tools for PCS that you can use as well. The approach is the 5th character in a code. Again, you can click on the question mark and it will give you the definitions of the approach. And unfortunately, I don't have more time to go over these in detail with you. Device is important because you must understand that a device is only coded if it's left in the body, and there are certain root operations that always involve a device, and so you have to be very cautious when you have to understand the definition of a device and when you're going to be coding those. Within 3M, we have a help tab, and we have tools and resources for the procedural coding system. You can access the guidelines, which you can also access at the CMS website. There is a reference manual. There is a body part key. This is very important. This body part key actually will tell you what body part to code something to that you may not have a specific body part for. For instance, if you're trying to determine what body part to use for abdominal esophagus, this body part table tells you to use esophagus lower, and so this is an excellent resource for body part. There's also a definitions manual, a device table, device key, and substance key. So before you begin coding in PCS, certainly you need to read the coding guidelines and review all of these resource tools. You need to understand the the definition of a root operation. You need to understand those definitions and also the definitions for the approaches. When we're looking at the medical surgical section, which is the one that we use most often, the section for this is 0 medical surgical. And then the body systems, we've looked at all of these different body systems, that skin and subcutaneous tissue. If you're suturing a laceration, you're choosing skin and subcutaneous tissue as your body part. If you're suturing a layered closure, it would be subcutaneous tissue and fascia. And again, you're only coding those PCS codes if you're performing that procedure as an inpatient. The root operation identifies the main objective of the procedure being performed. There's a specific definition for those root operations, and there are no combination codes in the procedural coding system. You don't break out a procedure and code its components, but we don't have combination codes in PCS. When we're looking at root operations, they are grouped together based on their intent. So we have root operations that remove some or all of a body part, and you can see those listed here. Then they also have root operations that remove solids, fluids, and gases from the body. And then root operations that involve cutting or separation only. Those are grouped together. And then there are root operations that put in, back, or move some or all of a body part. So if you have a body structure that's amputated and they're reattaching it, literally the root operation is reattachment. If you're doing a transplant, literally the root operation is transplant. There are root operations that alter the diameter of a tubular body part. So a CABG is coded to a bypass. PTCA is a dilatation. And then we have an occlusion. So for instance, if we're just narrowing the lumen, it would be occlusion. But if we're doing a tubal ligation, then we want restriction. We want that completely obstructed. These are the root operations that always involve a device, changing the same device, inserting a device, replacing a device, putting in a pacemaker, replacing a pacemaker. Those types of devices are included. Herniorrhaphy with mesh is supplementation. There are root operations that involve examination only, inspection and map. A procedure that an EGD without a biopsy is considered to be an inspection. If the EGD has biopsies, then it's considered to be an excision. There are root operations that are for something other than repair, controlling post-op bleeding, and then of course repair. And then we have some other root operations, alteration. Typically plastic surgery procedures code to alteration. Until this fall, creation was specifically for sex change operations, and then fusion, of course, is fusion of different joints. You must have the correct root operation in order to be able to appropriately code from the tables. The fourth body part, the fourth character is for the body part, and that's the specific body part on which that procedure is being performed. And then the fifth character is the approach, and that is the operative approach to reach the website. You can look in the definitions index, you can look at the definitions for all of these, and then there is an additional code that is utilized when robotic assistance is used as well. The sixth character is a device, and it's only coded when the device is actually remains in the body after the procedure is completed. They identify 4 types of devices, and again, those can be you can look in the device definitions for more information about those devices. The final character in a code is the 7th character, and it can be used. It can be a unique value within each of those sections or body systems. Many times the default code for that is a Z. Sometimes it's not, but many times that it is, and a Z indicates that there is no qualifier. Again, this is the link to the CMS website, which will be your resource for everything PCS. Now I have some examples that I would like for you to code, and once you can look at this and then pause it, and then I'll demonstrate finding that code in the procedural coding system. But for this, you're doing open removal of a portion of the left lower lobe of the lung. So we're not taking out the entire left lower lobe. It's a portion of the left lower lobe. My root operation is, my approach is open, and I know that because it's a portion that this is an excision and not a resection. So because I know the root operation, I can put excision, lung, left lower lobe, and the index will send me to the table. And when I get to the table, then basically what I do is plug in my approach, which I know is open, and I have no qualifier, and so this is my code. If I wanted to code this directly from the table, I could certainly do that. I would be in medical surgical, I would be in respiratory system for my body system, and my root operation is excision. Once I choose that, then I have to choose my body part, and my body part is the lower lung lobe left, and my approach is open. There's no device and no qualifier. And I hope that's the code that I have on this slide. 0BBJ, so actually lower, I'm sorry, in my example that I just did for you, I chose upper lobe, G, instead of lower lobe, J. So 0BBJ, 0ZZ. Now, if we're removing the left lower lobe of the lung, then we are performing a resection because the lobes of the lungs are subdivided. And I can put in resection, lung, lower lobe left. The approach is open, and then what changes about this code is the root operation. I go from an excision to a resection. 0BTJ0ZZ is the code for this resection of that lobe of the lung. Open thyroidectomy with lymph node removal on the right side of the neck, and this is diagnostic. So I'm sorry, I'm probably going through these too fast. You can pause this, and then when you start it up, I'll be in the encoder. So I know that my this is a resection of the thyroid. So 0GTK is the table. When I get to the table, I am choosing the approach, and it's open. Then I'm also doing an excision of lymph nodes on the right side of the neck, and that is diagnostic. So if I go to excision, lymph nodes, neck, right, it takes me to this table 07B1. I choose the approach, which is open, and my qualifier is diagnostic. So my code for this excision of lymph nodes in the right neck, 07B10ZX. Laparoscopic cholecystectomy converted to open. So we know that we're doing an open cholecystectomy, and that is a resection of the gallbladder, 0FT4, open. I just have to choose the approach once I get to the table, 0FT40ZZ, and then this was converted. So I have an inspection of my gallbladder that I have to code. (0FJ4), I choose my approach, percutaneous endoscopic, and there's no device and no qualifier. The cholecystectomy would be the principal procedure. It would be sequenced first, and then I would sequence the inspection of the gallbladder. Open reduction with internal fixation of a fractured left upper femur. When we're doing this open reduction, we are inserting a fixation, internal fixation. We're inserting a device. So we know that we have to have a root operation that always involves a device. So the root operation for this is insertion of device in. And we're doing an insertion of a device in the femur, and it is the left upper femur. So we choose left upper. When we get to the table, we have to choose our approach, and if the approach isn't specified, if it's not inherent in the procedure, you code it to open. We would choose open, and then we have an internal fixation device. So our code is 0QH704Z for this particular procedure. Closed reduction of a fracture of the right radius. Now, if we have a closed reduction of a fracture, basically we're using a root operation that reflects that we are putting the bone back into alignment. So in our example, we have the radius, so we have upper bones, and the root operation that we use is repositioning, and it's the right radius, and so we choose radius right. And then this approach is external. These approaches are always external. There's no device and there's no qualifier. In the index, if I put in this root operation, for the radius and then choose write. It takes me right to the table, and then I choose the approach and then no device and no qualifier. So the code is 0PSHXZZ. And actually that concludes the information that I'm sharing with you. I'd be happy to answer any questions anyone might have. Again, the key with the procedural coding system is really understanding the guidelines, the root operations, and the approaches. Thank you very much for your time.